In the cranial nerves that we are going to start to examine them, we have 12 cranial nerves. We write them in Roman numbers. The first nerve is the olfactory nerve. We have 2 olfactory nerves. Actually, we have 2 pairs of every cranial nerve. So we'll ask the patient for the olfaction of each nostril separately. If the patient should close his eyes, I will offer him a familiar non-irritant odor, and I will test each nostril separately. If he can identify the smell, I don't have a problem with the olfactory nerve. In case the patient cannot smell anything, this is called anosmia. One of the most common causes of anosmia is common cold. A famous cause now is COVID-19. Another neurological cause for loss of smell, if I have a problem in the frontal lobe, because the olfactory nerve enters through the cribriform plate to the frontal lobe. If I have a frontal lobe lesion or accident or trauma, it might cause or might lead to anosmia. عايزك تغمض عينيك ما تفتحهاش. ايه الريحه اللي انت شاممها هنا؟
هو مشروب كاكاو.
ممكن تقولها بصوت عالي؟
مشروب كاكاو.
طيب والناحيه دي شامم ايه؟
زي برفان.
تمام. This is intact olfaction. The second cranial nerve we are going to examine now is the optic nerve. In the optic nerve, we should test for 3 things: the visual field, the visual acuity, and the fundus examination. The pupillary reflexes are shared between the second and the third cranial nerves, the optic and the oculomotor. So to test them, actually, because of the setting, it's quite difficult to do it properly, but for the visual acuity, I should be standing at the same level with the patient at his same level, and the distance should be 6 meters, which is not feasible. And I will start to count, we will do for counting fingers. In case you took previously in ophthalmology, they have Snellen's charts and different charts now for this visual acuity. The second thing will be the field examination. In the field examination, I will be standing exactly at the level of the patient with the distance 1 meter between us, and I will close one of my eyes and his ipsilateral eye. And then I will ask him when he starts to see my finger from the 4 cardinal direction of view. I should do each eye separately and then both eye conjugately, or the whole field. So we'll start to do the field now. For the fundus examination, I need an indirect ophthalmoscope. It's a GP task, but usually we don't do it in our department, or we don't do it in the clinical setting routinely, but actually it's one of the skills a GP should know. نبتدي بقى. هسألك سؤالين بس، هتقول لي أول ما تشوف صبعي بيتحرك قول لي هو فين. ماشي؟ غمض عينك اللي قصادي، يعني هنا هتغمض الشمال. أول ما تشوف صبعي قول لي عينك عندي ما تتحركش وراسك ما تتحركش. شفتوا؟ تمام. ظهر. جميل. الله ينور. This is intact and I will go. ريح ايدك. I'll go for the other eye for the same thing. This is for the optic nerve. The 3rd, 4th, and 6th are tested together. These are the muscles that control the extraocular motility. First of all, I look at the patient. Do I have ptosis or I don't have ptosis? In case I have ptosis or one of the eyes is closed, I will mention this and I will say I have complete eye closure or ptosis on the right or the left eye. The second thing I will test is the extraocular motility, each eye separately and then both eye conjugately, to test for the conjugate eye movement. After I finish the conjugate eye movement, I will test I should look for nystagmus. In nystagmus, we move the eye to the most eccentric point, sometimes a little bit high, and fix our finger or fix the stimulus and see if we can see nystagmus. In case we see nystagmus, we say, I saw nystagmus in one eye or in both eyes. Is it in the horizontal gaze or in the vertical gaze? Sometimes it's tricky that in nystagmus, it is a non-persistent movement. We call it a nystagmoid movement. This nystagmoid movement appears with weakness, like in myasthenia gravis patients. But when it's persistent, it's going like that. This is nystagmus, and in nystagmus, I should test for the cerebellar functions and the vestibular functions. We should mention to the patient that he will move his eyes, not his head. This is very important. عايزك تقفل العين دي. عين واحدة. شايف صبعي؟ ما تحركش راسك، حرك عينيك بس وبص عليه. خليك معايا بقى. للآخر. فوق. تحت. And I usually enter to the neutral gaze. Upward and lateral, upwards, downwards, downwards and lateral, downwards and medial, upwards and medial. العين التانية. معلش. شايف صبعي؟ ما تحركش راسك خالص. تمام. ريح ايديك الاثنين وهنعمل الاثنين مع بعض من غير ما تحرك راسك. This is normal movement. I don't have any limitations in any direction of gaze. And now I will test for nystagmus. بص على صبعي كده واثبت. I look if there is nystagmus or not. I don't have nystagmus. So we have finished the third, the fourth, and the sixth cranial nerves. In case I have palsy at one of the muscles, I should mention it. Which eye is affected? Is it partial or complete? And which nerve is affected? The third, the fourth, and the sixth, or the sixth. Now for one of the longest cranial nerves, the fifth cranial nerve, the trigeminal nerve. The trigeminal nerve has three divisions or three main functions: motor function, sensory function, and reflexes. His motor function is controlling three main muscles in the face. So the temporalis muscle, which is here, in case you put your hands above your zygoma in this depression and clench in your teeth, you will feel the contraction. We ask the patient to clench and release. So we'll feel the contraction and the release. The second group is the masseter. The masseters, we have two masseters on each ramus of the mandible. So we'll ask the patient to clench and release. The third group of muscles is the muscles of mastication, the medial and lateral pterygoids. We cannot test for the medial and lateral pterygoids with the patient closing his mouth. We cannot eat with the mouth closed. So to test for the muscles of mastication, I ask the patient to open his mouth and move the jaw from one side to the other, like that. What if the patient opened his mouth and I found that the jaw is deviated towards the left side, like that? If it moves to the left side, this means that the right muscles worked, the left did not work. The deviation in the case of the fifth cranial nerve palsy, the deviation of the jaw is in the direction of the paralyzed side. We will mention this paralysis in the other cranial nerves too. This is for the motor of the trigeminal. I will do it now and then we'll go for the sensory and reflexes. عايزاك كده ريح راسك خالص، جز على اسنانك، فك الجزة، جز على اسنانك وفك تاني. عايزاك تفتح بقك وتحرك بقك من اليمين والشمال كذا مرة. الفك، عايزة الفك اللي تحت هو اللي يتحرك مش الشفايف. تمام. This is intact. For the sensory examination, we should use disposable pins. These disposable pins, we throw them after we complete the examination. We should test the ophthalmic division, the maxillary division, and the mandibular division. We should test on the right and on the left and see if they are equal or not. In case there is discrepancy, and I should test if this is organic or not. Any patient who tells you that exactly at the midline he feels the discrepancy, this is not seriously taken. Objectively speaking, if I have sensory loss on one side, so the patient will start to feel earlier or a little bit later after the midline. Because the cranial nerves, any nerve actually, they don't have a borderline like that. No, they overlap. So in case one of them is not functioning, an overlap zone is covered by the other functions or the other cranial nerve. So I'll now test for the sensory examination and ask him by a pin prick, because it's the most accurate, about the sensory. Is it equal on both sides or not? حاسس الشكة دي زي هنا؟ حاسس الشكة دي زي هنا؟ دي زي دي؟ فين فرق أعلى؟ مين أعلى؟ هنا. هنا أعلى؟ طب أول ما تزيد قول لي. كل ده زي بعضه؟
لا هنا زادت عن هنا.
يعني أول ما تزيد قول لي.
زادت هنا.
زادت هنا. أول ما تزيد قول لي.
هنا.
هنا. أول ما تزيد قول لي.
هنا.
Actually, the patient has sensory impairment on the right side that should be investigated. So I have discrepancy on the sensory on both sides. For the reflexes, we have two reflexes for the trigeminal nerve. One of them is shared by the facial nerve and the other one not. So we will go for the corneal reflex. The corneal reflex, I will use a wisp of cotton or Kleenex that is proper, something blunt, not sharp, and I will try to touch the cornea. The afferent or the sensations is carried by the fifth nerve, but closing the eye reflexly is carried by the facial nerve. So the afferent is 5, the efferent is 7. We never do this by a sharp object, please, because this is a very silly mistake. And it's dangerous to the patient too. So we don't use sharp objects, we should use a blunt wisp of cotton, sharp wisp of cotton to do something like that. The other reflex will be the jaw reflex. In the jaw reflex, I ask the patient to open his mouth, relax a little bit, and tap on the jaw. The normal response is no response or very minimal contraction. But if I find the jaw is exaggerated, the contraction is pronounced and exaggerated, this means I have exaggerated jaw jerk. The afferent is trigeminal sensory. The efferent is trigeminal motor. They relay at the pons. The center of the trigeminal nerve is in the pons. So as a rule in the reflexes, if I have an exaggerated reflex, so the pyramidal above this reflex is impaired. To have an exaggerated jaw, this means that the pyramidal above the jaw or above the pons, above the jaw reflex or above the pons, the pyramidal is interrupted on both sides. This can happen in the brainstem or above the level of the brainstem. So when we find an exaggerated jaw jerk, we call it pseudobulbar palsy. Bulb of the brain is the brainstem. Pseudobulbar means it might be in the bulb or not. True bulbar palsy, when I find cranial nerves paralyzed, this is definitely something in the brainstem. But pseudobulbar palsy means bilateral pyramidal above the level of the pons. It might be bilateral midbrain, white matter, midbrain, internal capsule, white matter, cerebral cortex, midbrain, anywhere but above the level of the pons. Now I will start testing for the corneal reflex by a wisp of cotton. That is very fine. We should touch the cornea, not the sclera, because the cornea is more sensitive. It has a very high nerve supply or sensory supply. بص على ايدي صبعي كده هنا. This is intact. And then the jaw jerk. هتفتح بقك نص فتحة، ريحه خالص. I can tap on my finger or I can tap ريح بقك تاني، ريح بقك افتحه. Or directly. This is slightly exaggerated. So we should test if the patient has something or not. The next cranial nerve is the nerve that is responsible for all the muscles in the face. Actually, I have above 80 muscles in the face that are supplied by the facial nerve. The facial nerve have 5 functions: motor function, a sensory function, reflexes, autonomic function, and emotional fibers. So to test them for the motor functions, we test the upper half of the face, then the lower half of the face. The upper half of the face, I should test the patient for 3 main muscles: the frontalis muscle, the orbicularis oculi, and the frownis. So I will ask the patient to raise his brows, frown, and close his eye forcibly. Sometimes, in case of doubt, I might open the eye, but I don't have to do it forcibly because these are very gentle muscles. In his lower face, I need to see a yellow smile to see the nasolabial fold, and his teeth. I ask the patient to show me his teeth. And with this smile, I'm sure of the orbicularis oculi and partially the buccinator. Then I ask the patient to blow with closed cheeks and see if they are equal potency or equal power on both cheeks. The last thing is to whistle. Not everyone can whistle. So in case I have the upper muscles intact and lower muscles intact, I will say that the facial muscle, the motor divisions are intact. What if I find that the upper face and lower face are impaired, for example, on the right side? This means that there is a lower motor neuron facial affection on the right side. In the lower motor neuron affection, I have affection both upper face and lower face. In case I have an upper motor neuron affection at the level of the midbrain or above, I will have only the lower face affected. Why? Because the upper face receives mutual supply. It receives ipsilateral nerve supply and contralateral, it gives on contralateral nerve supply. So each side of the upper face have dual supply, ipsi and contralateral, while the lower face doesn't have this. So in case of an upper motor neuron lesion, the lower face will be deprived of the supply, so we'll see the affection only in the lower face. The second thing we do for the facial nerve is testing the reflexes. One of the reflexes we have mentioned with the trigeminal nerve. So the corneal reflex is also a reflex for the 7th or the facial nerve. The third thing will be the autonomic function. Testing for the autonomic function, actually we don't do it as a neurologist much, but it's testing for the lacrimal affection and the sublingual and submandibular salivary glands. Then we have the sensory. In the sensory, we have two things. We have superficial sensory affection in cases of facial. If I have, for example, Ramsay-Hunt syndrome, we have vesicles in the external auditory meatus because the sensory area or the dermatome supplied by the facial nerve is in the external auditory meatus. But it has a very essential function too, which is the taste sensation. The anterior 2/3 of the tongue are supplied by the facial nerve. And the facial nerve, the chorda tympani, enters to the tongue through the lingual nerve, which is a branch of the mandibular, and it gives us the taste sensation. While the superficial sensations of the tongue are coming from the mandibular nerve, which is the 5th cranial nerve. Remember this. So in case I want to test the taste, I will ask the patient to introduce his tongue. I will dry the tongue. I will put crystals, nothing liquid, first on the right side and then on the left side. Why? Because if I put a liquid, it will spread on the tongue, and then I don't know if the patient is seeing or tasting it by the right or the left side. So each eye, I will put crystals on each side and ask the patient, which taste is this? After that, we have the emotional fibers. We have emotional fibers. The emotional fibers are carried through the facial nerve because we express our emotions through the muscles. And actually, true emotions are contagious. To test for the emotional fibers, I should say something funny to the patient to help him laugh. But it should be really funny, because if it's not funny, it will not work. In case the patient can smile, this means that the emotional fibers are intact. And in case the emotional fibers are lost, then I know that this is a sign of lower motor neuron affection of the facial nerve. Nothing not related to the facial, but I should mention it because it's a very common mistake that we try to fight for a very long time, but it's not, we're not winning. The glabellar reflex is not a test for the facial nerve. The glabellar reflex is a test for the extrapyramidal system. Two, when we do the glabellar reflex for Parkinsonian patients, we do it on the face. But having a glabellar positive reflex does not mean I have facial affection, it means I have Parkinson. So it's not a part of the routine examination of the facial nerve, it's not a test for the facial nerve at all. Now we'll start to do the facial examination on the patient. Now we'll go for testing for the facial nerve. عايزاك الأول تغمض عينيك الاتنين جامد، زر على عينيك جامد. تمام، افتح عينيك. عايزاك ترفع حواجبك الاتنين لفوق، تندهش. The corrugations are equal on both sides. ريح عينيك، عايزاك تكشر أكتر تكشيرة عندك. عارف ال 111 اللي في النص دي؟ آخرك في التكشير فين؟ ده جامد يعني. لا مش تقتم، تكشر يعني عايزة تقفل كده جامد. تعرف؟ It's not properly tested the frontis. And then we'll see the lower face. عايزاك توريني الضحكة، عايز ضحكة صفراء. عارف الضحكة الصفراء عامل ازاي؟ عايزاك توريني اسنانك كلها، طقم كله كده يطلع. الله ينور. بعدين عايزاك تنفخ وانت قافل شفايفك. لا، ايوه تنفخ كده نشوف. And we compare the power on both sides. تعرف تطفر؟ Even the whistling is intact. So this is for the motor function. We don't do the sensory for the external auditory meatus, and we don't do the autonomic usually, the lacrimal and sublingual nerves. I tried to give him something to laugh at, but I think it's embarrassing for the patient, and we will go for the taste sensation. غمض عينيك. طلع لسانك لبره. I will dry it first, and then I will give him something to taste. خلي لسانك بره خالص. أنا حطيت إيدي على لسانك دلوقتي، عايزاك تدوق كده، دخل لسانك جوه ودوق كده. مش عارف ده طعم ايه؟ اما يدوب كده هيبان. You cannot taste anything unless it's liquefied. حسيت طعم حاجة؟ خالص؟ طب نجرب تاني كده. ده طعم ايه؟
كاكاو.
Okay, he succeeded to know the taste of the thing I put it on the tongue. By now we have finished the 7th cranial nerve. The next nerve will be the vestibulocochlear nerve, which is the 8th cranial nerve. The vestibular part is related to balance, the cochlear part is related to hearing. So actually we are going to test for the hearing. Remember, we saw for the vestibular part the nystagmus. In case I have nystagmus on each of the eyes, this might indicate that the vestibular nerve is affected. There are further tests for the vestibular nerve not done routinely in the clinical examination. But for hearing, for the cochlear part, I can ask the patient to test the patient for fine sounds, like putting my hands next to his ear and see if he can hear this fine sound. The second thing is giving him a whispering sound, like 77, 66, something within us, whispering sounds. So in case he can hear it properly, which is a very fine sound, or tell me the number I told him, this is normal and intact. And I do it for each ear separately. Then I go for tests with the tuning fork with the frequency of 256 and test for the Rene, Weber, and Schwabach, which are tests for to differentiate between sensory neural hearing loss or conductive hearing loss. So I'll start first with the hearing. عايزاك تقفل ودنك الشمال مثلا. سامع الصوت ده؟ شوية. طيب هقول لك رقم وقول لي هو رقم كام. كام؟
77.
Which is intact. Then I will go for my tests with, I should do it on the other side too. Then I will go with the Rene test. In the Rene test, I put this on the mastoid and wait till the patient tells me he cannot hear the conduction anymore. This will differentiate the conductive versus sensory neural hearing loss. After stopping in the bone, he can still hear it from the air. وقفت الذبذبة دي ولا ما وقفتش؟ أول ما تقف قولي. شغالة؟
وقفت.
وقفت. سامع حاجة كده؟ مش سامع برضو حاجة. So actually both might be impaired. In case I put it here, after the conduction through bone is stopped, the air conduction is still working and the patient can properly hear it. I do it on the right side and then the left side. The next test will be the Weber test. In the Weber test, I put the vibrating tuning fork in the middle of the forehead. ريح ايدك. حاسس الذبذبة دي؟ خالص؟
بسيط.
على اليمين زي الشمال ولا في ناحية أعلى من التانية؟
لا.
زي بعض. It should radiate, the vibration should radiate to both sides equally. In case I have something that is radiating higher to one side, this is usually where I have conductive hearing loss, because this will make the patient hear it via the bone higher. The third test is the Schwabach test. In the Schwabach test, I do like the Rene test. I do hit it and vibrate it and put it on the patient's mastoid. حاسس الذبذبة دي and compare it to the normal examiner or the normal subject. أول ما تروح قولي. I can still hear it. So I'm comparing the patient's conduction versus a normal subject's conduction. This is for the 8th cranial nerve. 9, 10, and 11, we have a complex network of nerve supply. The glossopharyngeal, vagus, and the cranial accessory are tested together. We test for 3 functions. First, I see the patient's uvula and see if the uvula is central or vibrating or not. In case I have a central and vibrating uvula, this is normal. In case I find that the uvula is deviated to one side, it is usually deviated towards the healthy side, because imagine this is the uvula central and ask the patient to say ah. When he says ah, if it's vibrating and central, so the right and left are functioning. But what if it's deviated to one side? This means the healthy muscles worked and the paralyzed muscles didn't work. I do this after depressing the tongue with the tongue depressor to be able to see the uvula. The second thing we do is the glossopharyngeal or the gag reflex. This is a test for the glossopharyngeal nerve. The glossopharyngeal carries the sensations in the posterior third of the tongue and carries the gag reflex on both sides. So I should compare right with left. Remember, I should touch the wall beyond or behind the uvula. The third test for the vagus and glossopharyngeal, after seeing the uvula and the gag reflex, is also the tone of voice of the patient, which we have previously tested in the speech and articulation item. So I will start now to see with the patient. I will go with the tongue depressor, usually with a source of light to help me visualizing. هتفتح بقك هبص كده. I can see the uvula central والآ it's vibrating, and I will start to touch the glossopharyngeal wall right and left as quickly as possible. The gag is intact on both sides. This is an irritating thing to do for the patient, but actually it's very beneficial for the patient too, because the upper airway reflexes are protective reflexes to our upper airway and the lung. A patient with no gag reflex or who has paralysis in the vocal cords or the vagus nerve, he will be more prone for aspiration. So any general practitioner should be able to assess the upper airway reflexes like that. So again, we see the uvula, central vibrating or not, and we see the gag reflex. The cranial 11 or the accessory nerve has a cranial branch which is functioning with 9 and 10, and a spinal branch. In the spinal branch, I'm going to test for two muscles, the sternomastoids and the trapezius. I test the sternomastoid from the front, the trapezius from behind the patient. The sternomastoids, I can see them each muscle separately or both together to see the chin. In case I have bilateral sternomastoid paralysis, then I will see something called drop neck. If I can see a patient with a drop neck, this is severe affection of the muscles. In the trapezius, I will come from the back of the patient, ask him to raise his shoulder, and I will start to depress the shoulder from the back. We'll start to do them now. The sternomastoid first. عايزك تزق بدقنك على ايدي. جامد جامد جامد. أنا I'm looking to opponent sternomastoids. ريح. زق بإيدك دي على ايدي دي بدقنك على ايدي. And I will see the contralateral sternomastoid. طب عايزاك بدقنك تزق على ايدي تحت. Intact. هستأذنك تقف. لا اديني ظهرك بقى. ارفع كتافك لفوق جامد 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 جامد، تخلينيش انزلها. Intact. This is the trapezius. شكرا. اتفضل. This was for the 8th cranial nerve. The last cranial nerve, which is the hypoglossal nerve, is motor to the tongue. To be able to assess the hypoglossal, I will see the tongue at rest, and then I will ask the patient to introduce his tongue out to see if at rest to see fasciculations. When he introduces his tongue outside the mouth, this is testing for if I have deviation at the tip of the tongue. After that, I will see the power of the tongue through the cheeks, which is called the bonbon sign. If it's bilateral, equal, and potent, this is normal. So I will ask the patient again to do these tests. If he points his tongue and he deviates, the deviation is towards the paralyzed side. We mentioned this previously. So in the 5th and 12th cranial nerves, the deviation is towards the paralyzed side. While in 7 and 10, the deviation is towards the healthy side, and it's called the rule of 17. افتح بقى كده، عايز ابص على اللسان. ريح لسانك. I cannot see any fasciculations. طلع لسانك لبره كده. I can see some fine tremors here. اقفل بقك تاني. عايزاك تزق بقى بلسانك هو جوه بقك على ايدي على خدك هنا. زق جامد 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 والناحيه دي. جامد جامد جامد. This is intact bilaterally. So the hypoglossal is nerve. The hypoglossal nerve is intact. So we have finished the cranial nerve. The next step will be the motor system examination. Thank you very much.